measuring let's say 13 centimeters in the mid-clavicular line, depending on where you took your image. Now you are done with echogenicity, this and that, and then the dimension. Is the size normal or abnormal? We stated it here without problem. Okay. We also have, we know that we have vessels and then within the liver. Are they dilated? Are the hepatic duct dilated or they are normal? We also have to state, because dilatation of these hepatic duct may cause what? Processes, jaundice and other pathologies within the patient. So let's comment on these things. Portal veins and hepatic veins, they are also part of the liver. Are they normal? Because dilated portal veins greater than 30 to 15 millimeters may signify what? Portal hypertension. So if they are all within the normal limit, let's also state them, because any effect with these vessels may cause what? Non-compliance, okay, and then cause more problems. So portal veins and hepatic veins. Of, let's say, normal caliber, okay, or normal limits. Are the hepatic ducts dilated, the biliary system, are they normal, or they are dilated? If they are normal, it's okay. So they are normal, right? Then we can say that the hepatic ducts are not dilated. So no intra or extra hepatic biliary dilatation noted. You are done. This is your normal ultrasound report on this liver. Okay. Now, because you know the normal, how it appears on the sonogram. If there is any abnormality, okay, you have trained your eye in such a way that if there is anything within the liver, it should be normal. If there is anything aside normal, then it may signify a pathology. Okay, so this within, you scan, and then this time it is not homogeneous as it used to be. But about 99% or 95% of the liver is of homogeneous. So you may say that the liver is largely of normal epigenetic, but what? Largely homogeneous parenchyma texture. Okay, you look through the portal vein, the hepatic veins, they are all normal. Okay, so not in this part. You come to this part. Where is the location of this lesion? In the right lobe. So you can say it. Noted within the right lobe. That is where you saw the lesion. Okay, so noted within the right lobe. Of the liver. Okay? What are you seeing? It is what actually you are seeing on the sonogram. Okay? What actually you are seeing. Not what you call someone to confirm. Because ultrasound is operator dependent. And then it's based on what you are seeing. Okay? So within the right lobe, there is what? What I say, is it well defined or ill defined? It is well defined because we can see all the layers. Okay, it's a well defined. Is it one or two? If it is one, we can state it is solitary. But if it is two, we can say multiple. Okay, so it's not a well defined solitary. Notwithstanding, it is solitary, it is one. What is the echogenicity? Is it hypo or hyper? So it's what? So now we are describing, you are seeing this part, and I'm also seeing this hypoechoic because it's dark here. Okay? Okay, solitary hypoechoic. Okay, mass. Why mass? Because we said they are space occupying lesions. they are occupying the space inside the liver or the organ. Okay, so we can have a quick mass. What is, we can measure the dimension of this. Let's place our caliper here. Let's go to measure. Measure. We measure from anterior posterior and then left to right. So A by B, centimeters or millimeters anyway. Okay, measuring A by B, centimeters or millimeters anyway. Okay, ultrasound features suggestive of that one. Very soon we'll come to those things. Are you okay? If it is hyperechoic, we also change it. If it is this, okay, so you stated that there's a mass within, but you made it clear to us that the hepatic that are normal, because sometimes there may be a mass within the liver that may cause obstruction of the biliary system, and then the intrahepatic that may become dilated. By this time, the lesion is there, but it's not causing any dilatation of these ones. So we're reporting your report here. Are you okay? Okay. Now, pathologies of the liver. Pathologies of the liver can be grouped into two. Basically, pathologies of the liver can be grouped into two. We have focal liver lesions, and then we have diffuse liver lesions. So focal, and then diffuse liver lesions. Some lesions do not cause an increase in size of the organ. They do not cause an increase in size of the organ, okay, of that organ. Those that mostly do not cause an increase in size of the organs are what? Focal liver lesions. Those that what? Do not cause an increase in size of that organ, of the organ, are what? Focal liver lesions. And those that mostly cause an increase in size of the organs are what? Diffuse or diffuse liver masses. One after the other. Focal. I found this happening. If it is focal, Fatch system, you can find it in any book. And then the Famehepca system for diffuse. For diffuse. Fatch, what do I mean? Let's take them one after the other. F. For what? F for what? Okay. A. Adenoma. Hepatic adenoma. Alright. C. Cyst. Being complex or simple. And then when it is simple, when it is complex, we know the differential diagnosis. And then H. Hemangioma. Okay. And then diffuse. FA is what? Fatty liver. Fatty fibrotic pattern. And then centrifugal pattern. So you can't do that. Fatty liver. M is what? HE. And then CA. Carcinoma. Yes. And then what else? C. C is what? Cirrhosis. Cirrhosis. And sometimes another F, so the F was 2. The C is reaction. Yeah. Okay, the A. A is the abscess, sorry. abscess. Fatty liver abscess, metastasis, and then the whole lot. Okay, so note these points are very important when you are describing pathologies. The location, is there posterior enhancement, is there posterior shadowing? Okay, you should factor all those points into view. Okay, if it is heterogeneous, because you know what heterogeneous is, posterior enhancement, posterior shadowing, you should be able to identify. After the other, hepatitis, clinical history of hepatitis. What are the clinical history? Inflammation. So with this, you shouldn't even, okay, you shouldn't even go back to your notes and then review them. If hepatitis, inflammation of the liver. Mr. Martin, have you been taking alcohol these days? Why is the doctor asking this question? Because when we look at the facial appearance of you, we can see that, Martin, you are taking a lot of alcohol. Okay, all right. You are taking a lot of alcohol. Now to stop drinking alcohol. Doctor, okay, thank you, sir. Immediately from the consulting room, this doctor, I've never seen him in my life again, telling me to stop drinking alcohol. I'd rather drink and die. Okay, and then you know the process. What happens? The last time I took my time and described how when you take alcohol, what happens to your system. Okay, and then you realize that when you take in alcohol, your alcohol level concentration increases. Okay, and what happens is alcohol level concentration increases. And then what happens? Okay, and then it will get to a point where there is hydrolysis, so many processes taking place. The whole process taking to what? Acetaldehyde. Okay, acetaldehyde. By alcohol dehydrogenase, that's an enzyme. And then they are toxic. These substances are very toxic. And then they may cause damage associated molecular patterns, which may eventually cause scarring and fibrosis. And then you are getting into the later stage, cirrhosis. Okay, so in acute phase, when there is an acute injury to the liver, what happens actually is that the body may try to fight against that. The liver may try to resolve that issue, either by disease or chronic alcohol abuse. The liver may try to fight against those things. Okay, so when there is an injury, what happens is that we have all those signs coming into play. Inflammation, what are the signs? The patient right upper quadrant pain. Okay, and then what else? Okay, and then what are we supposed to see on the sonogram? I explained that there will be edema. The size of the organ may increase in the acute phase. So for acute hepatitis like this, what happens is that there is decreased, that is sonographic appearance, decreased echogenicity of the liver parenchyma. Okay, with increased visualization of the portal vein walls. The echogenicity becomes hypoechoic, and then we have hyperechoic, the portal vein, accentuated brightness of the portal vein, appearing as a starry sky appearance. So now we have the liver dystrophy. We have what? Assuming this is a portal vein. Cleansed, okay, hyperechoic. And then the parenchyma of the liver becomes what? Hypoechoic. Hypoechoic. Okay. How many hours now? I think I have just few minutes to write. Okay. Increased visualization of the portal vein walls with decreased visualization of the liver parenchyma. So hypoechoic liver, hyperechoic portal veins diffusely. Okay. The opposite of this is what? Fatty liver, where there is increased visualization of the portal vein walls. Sorry, when there is decreased visualization of the portal vein walls with increased visualization of the liver parenchyma. So the opposite of acute hepatitis is what? Fatty liver. Okay, and then cirrhosis, we all know